get my slide up there. Good. Oh. Hello. Welcome to Days of Your Lives. Oh, that was the TV channel, sorry. So welcome to the this month's ECHO program. And you know, I've been doing this now for 5 years, and after 4.5 years of trying to get physicians to change their practices, I thought we'd try a new approach the last 2 months. The approach is to really use the infection control people, the pharmacists, people involved in the day-to-day, management of the hospital and infection control, and use them as sort of get them more involved, and so they can hopefully, change some of the habits that physicians are doing. So it's also fun to review some of the recent topics that are coming out, updating you guys. And we have Jessica here and Mike, and we'll get their input. So I want to hear also what people are doing too when we talk about some of these topics. This is more of just an interesting article. This is called Antibiotic Use Earlier in Life Associated with Increased Risk for Colorectal Adenomas, which are cancer precursors. So, we like to beat up on antibiotics, and this is just one more reason. So this was something, in 1976, there was something called the Nurses' Health Study was set up, and they asked young to middle-aged nurses to sign up. 1976, 120,000 signed up, and they were going to follow them prospectively over for the next decades, and it's been going on now over 40 years. And what they wanted to do now is about 16,000 of those 120,000 people, they had a history of antibiotic use. They were able to quantitate how many antibiotics there were in the various age epochs, from 20 to 39, 40 to 59. So these are people, they knew their antibiotics, 20s to 39, 40 to 59, and they also had screening colonoscopy. So they wanted to see, the study was to look at, we had 50 years of data, 40 years of data on these women, what role, if anything, as a risk factor for the development of adenoma, which is the precancerous development, did this influence at all? So they took these 16,000 women who had antibiotic history and colonoscopy history. They looked at if they had taken antibiotics for more than 2 months at age 20 to 39 or 40 to 59, and more recently. They were then prospectively studied over the last 15 years for the development of colorectal adenomas. They didn't tell them to get screened, but these were people getting screened. And the results were very interesting. They found that women who had used more than two months total antibiotics during the 20 to 39 or 40 to 59 period had a significantly increased risk of having adenomas when they had colonoscopies, which adenomas obviously are a precursor to cancer. They found no association with recent antibiotic use, okay? And so what their conclusion was that this probably is that the use of antibiotics probably disrupted their microbiome system and allowed for this change in the biology of their colon, promoted colorectal neoplasia. And so, they talked about the microbiome causing obesity, diabetes, autoimmune diseases, and it seems like upsetting the microbiome also may increase your risk for colon cancer, or at least colorectal adenoma. So just one more thing that antibiotics are not our friends at all times. So I'm not going to tell you what state this study was done in to protect their reputation, but this is infection control people and other nurses, this is showing that there's some bad things still happening. And this is a study came out last month in the Morbidity and Mortality Weekly Report. It was called Herpatitis C Transmission from an Inappropriate Reuse of Saline Flush Syringes for Multiple Patients in an Acute Care General Hospital. So this hospital, a nurse was known by a number of people to have partially filled saline syringes on her desk. And so they asked her what she was doing. And so she worked on a telemetry ward where everybody, because it was a cardiac ward, they all had to have IV access. And so what they were doing was routinely flushing all these IV accesses. And what she would do is she admitted to reusing these saline syringes for over 6 months. She thought this was a cost savings measured. As no fluids were withdrawn into the syringe. So she would just flush it, but she wasn't withdrawing, she was just flushing it. And she thought that this would save some money on these saline syringes. And she admitted she was never taught to do this in nursing school. So she worked on this ward for 6 months before she was noted to have this bad habit. So the hospital voluntarily notified the health department. There was about 400 patients got registered letters. They were offered free HIV, Hep C, and hepatitis B screening. And they were able to track down 2/3 of them. And it turned out 2 patients had hepatitis C. One that was on the ward knew they had a Hep C already, and there was another patient who was on the ward at the same time. He also had a genetically identical Hep C as was on the other person on the ward. They were not related to each other, they never known each other, and so the only association was that they're both in the hospital at the same time. And this is a very unusual genotype of hepatitis C. They sequenced it so it was identical. So they felt that this lady who was using a saline flush had actually infected this person, okay? And their recommendation is that we should use this as a teaching lesson, and that we need to continually review safe injection practices at their facilities, okay? So this sounded like deja vu all over again, because speaking of the devil, this was in the newspaper. Dr. Dipak Desai just died 2 weeks ago at Renown Medical Center here. And he ran a GI clinic in Las Vegas. He had a whole bunch of doctors working for him. And they would do basically sham colonoscopies on thousands of patients. They tried to save money by reusing sheets, doing quick examinations. And they used contaminated syringes. They were using single-dose vials of, what is it, propofol? Is that what stuff they used that not people have?
I think so,
yeah. Yeah. What they were doing, they had these single-dose vials, but they were reusing them and injecting the patient and using the same syringe. And he went on for a number of years, and the city eventually closed his office in 2008. He personally made $200 million, so good for him. He infected over 100 patients with hepatitis C. One of the patients died in 2013, was found guilty of murder. He and his head nurse were both sentenced to jail. He never lost his license, and 13 of his practice associates are still licensed in Nevada. So, you know, we take it first. I mean, the thing is that you got to keep your eyes open and make sure, maybe just routinely review these kind of practices, because we have new nurses coming on, and they may not be aware of this kind of thing. So I just thought, as infection control people, you may just want to check and have a look at that we're only using saline flushes once. So he just passed away. He was in jail, and they sent him to Renown, and apparently passed away. I don't know from what.
Hepatitis C.
That would be good karma. All right, so this is just an interesting study that came out in MMWR last month, and it was from Spain. It was called An Outbreak of Salmonella Typhimurim Associated with Playground Sand in a Preschool Setting. So they had it was a school in Madrid. 300 kids went to it, and it was 24 kids developed Salmonella gastroenteritis over the space of about 6 weeks. It was non-typhoidal, so this is the typical salmonella you get from eating eggs or chicken that's not cooked properly. So there was nothing unusual about the strain, but these kids were coming down with it, 24 out of 30, 300 at least. So they went to the school and they examined the facilities. They checked the food, the water, the drinkable water. They checked the personnel. There was no animals kept in the school, and they were all completely negative. And this epidemic continued. So they thought there must be some kind of common source exposure to these kids. And so it turns out the kids were all playing in the sand lot behind the school, and there was trees around it. And there was a whole bunch of birds in the trees. And so they took multiple samples from the sand, and all of them grew this Salmonella Typhimurim. Salmonella Typhimurim we usually think of as only seen in animals, and like It's never been reported in birds or wild or domestic pork. And this strain, which was in the kids, was found to be one strain that had previously been seen in these birds, but not usually associated with humans. And so they closed the sandlot, and that ended the epidemic. So if you start seeing salmonella, it's interesting. I don't think it's just food they're eating, but maybe actually playing in the sand. Well, hold it until we find a parked car.
That's funny.
I left my office yesterday. My car had been covered in droppings, so I thought maybe the birds had a sneak preview of my slides and were not happy. All right, so this is stuff I want everybody's input on, and this is more relevant to the hospital situation. So there's approximately 1 million knee and hip replacements done in the hospital, and traditionally most orthopedic doctors order preoperative urinalyses because their concern is that if they have a urine bacteria in the urine, it's going to increase their risk of developing a postoperative infection. And so traditionally screening urine cultures are done whether or not the patient has symptoms. And the question is this appropriate? Because if we keep on giving people antibiotics, we don't need antibiotics. You have risk for drug reactions, C. diff, drug resistance, etc. So this is apparently a premier orthopedic hospital in Canada called the Toronto Orthopedic Hospital. And what they did was they looked at the last 3 years of orthopedic surgeries. They had done over 3,000, and they found out 90% of them were getting urinalyses done. 12% of those urinalyses, so a few thousand, were positive, and not a few hundred, a few thousand were positive, and most of those were being treated. And during that time, when they had those 3,000 retrospective look, not a single what's called prosthetic joint infection developed, except they had one that had E. coli in it. But otherwise, they had one infection out of thousands of cases, and one had E. coli. So then they got together the infection control people, the orthopedists, infectious disease doctors, and said, do we really need to do this? And so what they removed it from the preoperative list. And if somebody did send a urinalysis down, they went back that we have decided this is not appropriate. We will hold the urine for 24 hours, and if you don't call us, we're going to discard it. Okay, so the physician had the option of calling and say, I do want this done. And so if you look at the next slide, we show that this is the rate. On the left side is the black thing on the top was the amount of urine cultures, about 90% overall. On the very top of that, 90% of patients had urine cultures done. Okay, so out of the 3,000, by 2,700 of them had urine cultures done, of which 12% were positive. Then when they put the new rule in, go down the next line, over the next 2 years, or year and a half, they did 1,800 surgeries, and they had about 10% of urine cultures urinalyses were ordered, and the lab just threw them all away. And so the black line shows that basically no urine cultures were done. And so the question is, did not treating these positive urinalyses in asymptomatic patients, did it make a difference? And so going back to the old one, 1,891 cases were done where no preoperative urinalyses were done. They had 3 post-op wound infections, all were Staph aureus, which is not something you can find in the urine. So no urinary pathogens were found. There was no prosthetic joint infections. No urinary pathogens were found. They're just Staph aureus. And their conclusion at this excellent facility was that there was no role for pre-op cultures unless the patient is symptomatic, at which point you'd want to treat them. But basically, they just tried to break that habit, and it didn't really make any difference.
It'd be interesting if they looked at the occurrence of C. diff while they were treating, and then C. diff after they stopped treating the urine.
Yes. Yeah, we had a patient who developed C. diff and died at one of the local hospitals after getting Cipro for asymptomatic bacteria. That really woken us. So what are you guys doing in your facilities? Are you doing preoperative urinalyses and cultures in your patients?
Well, we recently are removing it from our anesthesia protocol. And then working on taking it to the ortho section meetings in the next month or so. Because right now it's on the orthopedic order set and the anesthesia protocol at our facility. And so we've removed it from the anesthesia protocol. We're trying to get them to remove it from their pre-printed order sets. So we'll be
Do you have
making a
that
statement.
article?
Oh yeah, absolutely. Well, there've been a couple now with very similar results.
Because, when you talk about asymptomatic bacteria in the past, a doctor's gonna not ask. If he sees a positive urine culture, he's gonna treat it. So the way to do it is to keep that culture result away from the doctor. And so, I think a doctor oftentimes feels obligated to react to something. So if he doesn't have a urine culture to react to, he's not gonna treat it. So by the time it gets to the doctor, it's too late. So I would hope that infection control people would look about trying to get off their pre-op orders, so that out of sight, out of mind, no one's going to treat it, because even though it doesn't cost much, you're giving people unnecessary antibiotics, and it's just not necessary. You're going to treat somebody who doesn't need it, putting them at risk, whether it's C. diff, drug resistance, etc.
When the Orthopedic Society came out with this recommendation, that was years ago.
Yes.
There was a big editorial by IDSA saying there is absolutely no literature that suggests these patients are at higher risk for infection. And so IDSA was totally against it, but they just did their own thing.
There's a podcast by Dr. Crispin in Washington. Anyways, he says he's sort of not an optimist. He says we're going to have to wait for this whole generation of doctors to die off. Anyways, you may want to look at your orders if you do orthopedic surgery at your place. Again, there's over and over again. This is a Premier Institute, and so they say they just dropped it. Okay.
Think of all that extra time the microbiology department had.
Yeah, really.
To run PCRs on demand.
Anyways, these are things we need to do. All right. So this is an interesting topic because we get coagulase-negative staph in the blood all the time, and everybody sort of throws it off as a contaminant. So it's the number one for positive blood flow is coagulase-negative staph. So coagulase-negative just means, coagulase-positive means that coagulates fibrinogen. That's Staph aureus. So Staph aureus immersion or coagulase-positive. Everything else does not coagulate fibrinogen in the lab, so we call those coagulase-negative. And those are the things that are not Staph aureus, Staph immersion. Those are like Staph epidermidis, Staph pseudocyticus. There's a whole bunch of them. And those are, unlike Staph aureus, which is usually a pathogen, the coagulase-negative staph are found on the skin. And so we say, oh, he's got Staph epidermidis in the blood. It's probably because the phlebotomist didn't properly, dry the top off of the bottles and wait 15 seconds. We always blame the phlebotomist for that. And we say it's usually a contaminant, okay? And usually they dismiss it as a contaminant when you get only 1 out of the 4 bottles drawn or positive. Say, oh, it's a contaminant. And then you say, oh, maybe it's a true positive 2 out of bottles, and both bottles are positive, especially if they both have the same organism. Let's say they say both Staph epidermidis, the susceptibility pattern is the same. So maybe this is a true infection. But when they look at these Staph epidermidises in the same bottle, they can, phenotypically, which means the resistance pattern identification is the same, but when they look at genotyping, we actually sequence the virus, sequence the DNA, they find that these are oftentimes unrelated genetic fingerprinting. So even when you have 2 out of 4 bottles being positive for the same, quote, bacteria, oftentimes they're unrelated. And so having 2 out of 4 bottles of the same things didn't seem to correlate at all. It was not a better predictor of a clinical infection than whether it had 1 out of 4. And what they found out is what we always do. It's like, how we talk about C. diff, you have to clinically diagnose this. It's much more useful if you look at the patient. Does this patient likely have a true infection? We get these people who are like found on the street, they've aspirated after drinking, their skin is dirty, they got coag-negative staph. There's no reason for them to have coag-negative staph in the blood. Coag-negative staph sticks to plastic, metal. So when you're talking about like central lines, heart valves, things like that, that is where you see it. They produce a biofilm. So if you look at that patient, says, do you think this patient would have an infection? Does he have a central line in? Has he had heart surgery? Does he have a lot of, sutures etc. that could be infected? Say yes, that seems like it. Does he have a fever? Does he have SIRS criteria? Then it's probably much greater likelihood that this patient actually has a coagulase-negative infection. So just saying 1 out of 4 or 2 out of 4 determines whether or not it's a positive, a true infection or not, is really worthless. You really have to use clinical criteria. Okay, so again, you have somebody just buying from the street is dirty, has a lot of coag-negative staph, having 4 out of 4 bottles. If there's no reason for him to have coag-negative staph, and no reason it hasn't presented that way, then I would ignore it completely. If he has 1 out of 4, but he's got essential line because he's got a Hickman catheter for his cancer, has fever, then I would say, I take this very seriously. So you can't just look at how many bottles are positive, whether or not the bottles have the same bacteria species to make that determination. I think this is a very helpful way to look at that.
There was a pediatric study that looked at time to positivity of blood culture. Did you read that? And I think the cutoff was, the time to positivity was one of the most important determinants on whether or not a blood culture was real versus.
Explain what that is.
The time from the blood culture drawn to when it, deems to the microbiology department that there's growth in that blood culture bottle. So that's time to positivity. The thought that the true pathogens have a higher inoculum, so it would hit that magic number to trigger a positive result. That time positivity seemed to be the best predictor of whether or not it was a real pathogen versus a contaminant.
And usually when they're contaminants, like 2 to 3 days later, because there's probably just a few bacteria on their skin, versus somebody has overwhelming Staph aureus bacteremia and it pops positive within 6 hours or something. So you have to look at the picture before you just blow something off as a contaminant or not, and also don't use the number of bottles positive. Okay, so a lot of things to look at. So that's just a way of looking at coag-negative staph in the blood. Does it fit the criteria? Are they sick, and do they have reasons for it? So let's go back to my favorite topic, which is C. difficile infection. And this was an article just came out that it was a meta-analysis from the Mayo Clinic in UC Davis. And they went back and they looked at 7,500 patients who had C. diff infection. And approximately 20% of them went on to develop recurrent C. diff infection. And they wanted to look at whether or not acid blockers, like Protonix, omeprazole, increase their risk for relapse. And so we know already that taking omeprazole acid blockers increases your risk for your first infection. The question is, if you're on that, does it increase your risk for relapse? And so they had, when they looked at those percentage of people who relapsed, 22% of those who are on acid blockers relapsed versus only 17% who are not on these medicines, which is about a 30% increased risk. And then they looked at things like age, comorbidities, cofactors, and stuff like that, and they found that it made no difference at all, even if you took that into consideration. So the takeaway from this study and previous reports is not only does acid blocking increase your risk for C. diff infection, but it also increases your risk for relapse. And so, it's worth, even though these are not antibiotics, you may want to just review the use of prophylaxis in your hospital. Oftentimes I see that at the hospitals that people are put on omeprazole in the hospital and they're continuing as an outpatient. They come to you 2 years later, they're still on it. They're not sure why they're taking this drug and nobody why they're on it. So you may want to just talk to your pharmacist or your hospitalist. What are the indications for prophylaxis using acid blockers, and make sure the patients are taken off it as soon as they can after their hospitalization.
I think there's a role for, similar to say an IV to PO protocol where you don't need a physician order. At Renown, we have a DC acid suppressive therapy if they don't need an indication. That the pharmacists are in charge, or responsible for implementing. And so I think there is a role for that if you can get together with your providers to find some criteria for your institution where you can DC that per protocol. I think you're going to have a big impact. You're going to see a lot of people leaving the hospital and then coming back on PPIs if you implement that appropriately, and hopefully decrease C. diff rates and decrease those recurrences. Yeah,
because you need acid to hopefully prevent the spores from germinating and causing an infection. So if someone's on the ICU, is there a role for these drugs?
Do you know?
Well, if you have a history, I don't know.
Yeah, I mean, there's certain, like, GERD or
Yeah.
other indication, true indication for a.
But in the hospital itself.
Well, initially in ICU, they're just giving more prophylaxis. And it should be stopped as soon as they are out of ICU, but they don't. They put them in ICU and, get them to the floor and they're on it and they get them home and,
And I see there's a lot of things about the kidneys too, that these are negatively affecting kidney function on some of these patients.
I didn't know that.
Yeah, I mean, with all things, the longer we have people on, the more we're finding out later that maybe they're not as good as we originally thought they were, or maybe or harm you in a way that we didn't know.
Yeah.
So does it increase what?
I don't know how good the data is.
But was it suggesting?
Yeah, so they're worsening renal function, and you can actually take them off and it actually improved it. All right, so this is a study, again, one of the things we've been learning the last year is, this PCR test for C. diff. And what the PCR test does is basically tells you that you have C. diff that has the gene that can produce toxin, okay? It doesn't tell you whether it's on or off, like a light switch, on or off. It just says, yes, this C. diff has the gene, has the potential for producing toxin, okay? There's a lot of C. diff that don't have the toxin, and most of the time the C. diff is not producing toxin, but the PCR test just says this person has C. diff. It doesn't tell you whether or not it's actually producing toxin, making the person symptomatic, or they're just carriers. So this was done at Stanford University, the hospital there, and they wanted to look at PCR rates in asymptomatic patients on admission versus patients who came in with diarrhea. And so what they found is that on admission, 11.8% of their asymptomatic patients were already PCR positive. So these are patients who didn't have diarrhea, and 11.8% of them were carrying C. diff in their stool. Okay, the ones that had diarrhea had a slightly increased risk. 15% of these patients with diarrhea were PCR positive, and 11.8 and 15.4 were, there's no significant difference. And so what that would tell you is that there's really, having a positive PCR test doesn't help you, doesn't mean that you have C. diff. It just means you're potential carriers. You have no idea whether or not that diarrhea is from the C. diff because you have almost the same amount of people who are carrying, don't have PCR. So then they looked at, how about the PCR? The PCR picks up the DNA for the gene. They say maybe somebody who's got C. diff has more than the C. diff in their stool, and that the PCR, that cycles itself based on until it becomes a positive, reaches a positive threshold. They said maybe the persons who have C. diff that's really infected, the PCR cycles quicker than if they don't have it. There was no difference. So they had no difference in terms of the amount of DNA in the stool, amount of C. diff in the stool. There was no difference in the positivity rate. So their conclusion was that asymptomatic C. diff carriage rate was similar to symptomatic rate, suggesting that the majority of PCR positive patients results in symptomatic patients are likely due to colonization. Disease-specific biomarkers are needed to accurately diagnose patients with C. diff disease. So what's this telling us that a PCR negative test says they haven't got C. diff, but a PCR test that's positive doesn't tell us why. They may be carriers. It doesn't tell you anything about whether or not the diarrhea they have is from C. diff. Is it from the laxatives? Is it from whatever's going on? And so I just wanted to review again that C. diff is a clinical diagnosis. Do not base it on the basis of a test result. It's not simply a positive test result. It's watery diarrhea. That's the cardinal symptom. Very watery, loose, mucousy diarrhea with colitis, greater than 3 loose stools, oftentimes with lower abdominal pain, cramping, low-grade fever, nausea, anorexia, and leukocytosis. Okay, and so we're going back to the future. I was just going to go back to here. The ELISA toxin test. Okay. The ELISA toxin test is a test that we replaced with PCR. And we said, oh, this test is not very sensitive. It's good if it picks it up, but if it's negative, we're probably missing C. diff. And we send it out for a PCR test and say, yes, it's positive. But what this toxin test does is, one, it first identifies that C. diff is present. It's called the glutamate dehydrogenase antigen. So if that's negative, there's no C. diff in the stool. But if it's positive, it then answers the question, is this C. diff producing the toxin? Is the actual toxin there? And so if the GDH is positive, it then reflexes over to actually, it's an ELISA test that identifies the presence of the toxin. So this is telling you, yes, you have C. diff, and yes, you're producing a toxin. And as that UC Davis showed, that if it's GDH positive but toxin negative, these patients, their prognosis is the same as if they didn't even have C. diff. It's just regular old diarrhea. So what you should be doing is hopefully doing in your hospital is, if you do the PCR, that's fine, but it doesn't tell you anything, okay? It just tells you have C. diff that has potential to produce toxin. Just because somebody has diarrhea and PCR positive, it doesn't tell you anything about whether or not the C. diff is the cause of that diarrhea. And so what we're doing and other hospitals trying to do is if it's PCR positive, then they're then getting the ELISA test to actually look for the toxin, using that, is that toxin present? And so what we're writing at Northern Nevada, we're saying this comment when somebody gets a positive PCR test, we're writing the C. diff PCR detects the toxin gene. Okay, it tells you that the gene is here. It doesn't tell you anything whether or not the light switch is on or off, but not the actual presence of toxin. A positive PCR toxin test, therefore, does not differentiate between asymptomatic colonization and active disease, which is what they just said in Stanford, too. When the PCR test is positive, additional tests will be automatically performed which detect the C. diff antigen, confirming the PCR test, and then doing the toxin itself. These tests may be used in conjunction with the patient history as an aid in the diagnosis and treatment of C. diff infection. And if the indeterminate results suggest testing be repeated on a fresh specimen. And so we're using this to really help guide us, and the residents I work at the VA are appreciating this. So if somebody comes with diarrhea, his white count's 9,000, his belly's soft, and it doesn't really have water, just mushy diarrhea, the PCR be positive. All it means is they're most likely just colonizers. And this test will really help guide you in terms of treating these patients. What do you guys think right now?
Absolutely.
Or
That's great.
moving towards the PCR and EIA with a similar report out on our lab. What we're questioning is the need to continue PCR if we're going to start doing EIA.
Well, we have a contract, so we have to do it.
You need the GDH because that just tells you the C. diff is there.
Right.
So you already know it's there.
Yeah, but it's complete. It's a complete test.
So well, the ELISA.
You can't get one without the other, is what you're saying.
Right, exactly, yes.
I VA did it for years.
The VA's online.
Oh, okay.
So we found this really helpful, but you have to educate the physicians, and I think they really start appreciating what's going on because, we all thought the PCR was a great test, but all it says is, doesn't tell us anything except there's a carrier. PCR is negative, they haven't got C. diff. 100%.
So if you weren't in a contract
Yes.
for PCRs, would you just go?
UC Davis is no longer doing PCR. They're just doing this test on their patients. And so,
you remember there was some question about how accurate it was. If it was positive, you knew you had C.
yeah, that's what I'm saying.
But I'm talking about the ELISA. If the ELISA was negative, and you thought it was still C. diff, you should repeat it. So I don't know how accurate does it. What's the accuracy?
But then what we were doing is we then send it out to stool for the PCR test and come back peasantly and say,
Yeah, I know.
But if you looked at that study in Davis, there was no difference. There was total overlap between patients who didn't have C. diff in their stool at all, who were toxin negative, and those who didn't. I mean, obviously, there's
Well, I'm just going by, that was the thought years ago. The ELISA was not that accurate.
not that sensitive.
If it picked it up, fine, you knew you had it. But if it missed it, you still could have it.
Yeah, but that's what we're showing it isn't. But then again, it's a clinical
Look at
diagnosis.
the patient.
Look, and also,
The main thing, somebody comes in with diarrhea and they got 35,000 white count.
right, you're going to
Pretty
treat.
much know.
Right. And this is the same concept. Look at the patient when you're dealing with coagulase staph in the blood, right? When all else fails, look at the patient.
I heard someone say that before.
So this is something in small hospitals you may want to think about. Because I think it's going to cut back on isolation, it's going to cut back on over-treatment, and exposing people to antibiotics they don't need. All right, so today we talked about coag-negative staph, we talked about PCR testing, we talked about look for your birds in your sandlot, and the C. diff test. The PCR test really doesn't tell us squat.
This is good.
You guys have any comments or thoughts about what you guys are doing, or? And the urinalysis, yeah, so, we can avoid the doctors, if you get the urinalysis off the list, if you start talking about not over-treating the patients, I think you can skip the doctors and you can really make big changes, because I think asymptomatic bacteria treatment is probably the major problem in hospitals, and C. diff is a big issue too.
Is there an indication for the UA pre-procedurally? I know there's no indication for the culture, but the UA itself.
Not really.
Yeah, they were reflexing over the cultures, and 12% of them were cultured. Just shows how much asymptomatic bacteria, but unless it's urologic surgery or they're pregnant, there's no role for doing that.
If any of these places want to initiate any of this, can we help them? I mean, if you have questions, call us and we can help you.
Yeah. All right.
Any questions?
All right. Thank you all.
Thanks.
Thank you.